What causes and how do we treat cerebral aneurysms and stroke? We'll discuss these issues and other common questions today on Health Talk. We're up next. Hi, I'm Dr. Eric Mazer. Today we're going to discuss stroke and cerebral aneurysms with Dr. Joshua Marcus. He's a neurosurgeon and endovascular neurosurgeon affiliated with the Western Connecticut Health Network. This is your first visit to the show, and I've really been interested to talk to you because it's such an interesting topic. So first of all, tell us what an endovascular neurosurgeon is, if you would.
Sure. So an endovascular neurosurgeon is a neurosurgeon who specifically treats disorders of the blood vessels of the brain. Then those diseases can range from stroke, they can range from aneurysm, or other arteriovenous abnormalities, or abnormalities between the connection between the arteries and veins. An endovascular neurosurgeon is someone who treats all these by going through the blood vessels themselves rather than needing to go traditionally, take off part of the skull and access the blood vessels that way. So we can do everything through a minimally invasive approach through the groin.
And you actually trained first in neurosurgery and then did endovascular neurosurgery.
I did, yeah. I did a full neurosurgical residency and then did a specific 2-year endovascular training fellowship.
Now, Josh, it's really common in our society for people to say, well, it's not neurosurgery. But then, is it neurosurgery? Is it as hard as everybody says?
It very much is neurosurgery.
Yeah, a lot of training. That's how many years did you train?
I did 7 years total of training after medical school.
Yeah, and then you had the 4 years of medical school to that.
Correct.
That's a sobering number of years.
It is. It was a long time.
So let's talk a little bit about stroke, because that's probably one of the more common things. And let's say a little, what causes a stroke? And we really have treatments for stroke now, because when I was in training, or actually even for many years, someone would have a stroke, we'd bring them in the hospital, try to make sure they didn't aspirate, and that was all we did.
Sure. So stroke is actually very common. So stroke is one of the fourth leading cause of death and disability in the United States each year, about 800,000 new strokes in the U.S. Annually. And the cause of stroke is typically an occlusion or blockage of a blood vessel that delivers blood and oxygen to a specific part of the brain. Kind of a broad term to describe all comers for stroke, but that is the general problem when we talk about stroke.
Which is exactly the cause of heart attacks too, except it's the blood vessels leading to the heart rather than the brain.
Exactly, and some people will call them brain attacks. Mm-hmm. So this can come from a blood clot that's traveled from somewhere else in the body. Very often that blood clot travels from the carotid arteries in the neck. Sometimes that blood clot travels from the heart. Sometimes it's even a blood clot that travels from the leg.
Yeah, and that's, just so people don't get too concerned, most blood clots in the leg get caught in the lungs. But there are some instances where they can get across the lungs, actually across the heart, and get into the brain.
Absolutely. The overwhelming majority of stroke blood clots typically come from the heart. In patients who have specific irregular heartbeats like atrial fibrillation.
And certainly people are learning about that because of the new oral anticoagulants, and everybody has AFib.
Correct.
On television.
Exactly.
Of course, we call it AFib, but it's AFib on TV, and that's an abnormality of the heart where the atria, the upper chambers, don't pump properly, and whenever you get stasis or blood doesn't move, it can clot.
Exactly, and so then sometimes the first place for that blood or that blood clot to go is straight up to the brain. The brain gets about 30% of the entire blood flow for the whole body. So if there's clot in the heart, it's got a good chance it's going to land in the brain.
And so I guess that is why we use blood thinners, the old warfarin or some of these new oral anticoagulant agents, to thin the blood to reduce the chance of the clot forming in the heart.
Exactly. And when that doesn't work, you run the risk of stroke.
Now, as I said, when I was young, we used to just watch heart attacks and strokes happen. And then, maybe it was 15, 20 years ago, there were some seminal studies that showed that if you could restore blood flow to the brain quickly enough, you could reduce the long-term outcome of the stroke. And that's progressed since then. So tell us, if you would take us through some of that history.
Sure, absolutely. So it started really with heart attack. A heart attack, the goal is to restore blood flow to the heart. And so there were developments using a very aggressive blood thinning or clot busting medications, and that medication is known as TPA, which is a specifically a clot-disrupting medication, worked pretty well in heart attack, and so it was expanded to be used in stroke in the early 90s.
They call it clot busters.
Exactly.
Genentech, I guess, made a lot of money on it, I think.
Clot busting is like a household name now.
That's right.
But that was expanded in the 90s to be used for treatment of stroke. And so you come to the emergency room, you're having a stroke, we think there's a blood vessel that's blocked, we give you this clot-busting medication, and we hope that that opens up the blood vessel in a timely fashion and you restore some level of neurologic function.
Now, it turns out, though, that the brain dies more quickly than the heart, so that the timing is even narrower for your ability to intervene. Isn't that true?
Absolutely. You're losing up to 1.9 million neurons per minute of lack of blood flow and oxygen.
Wow,
So
I didn't know they had a good number on it like that.
when time is brain, that's really what is meant.
So I think that it's important for our viewers, or for everyone, to understand what the symptoms are of a stroke, so they get to the emergency department as quickly as possible. Because we're really talking about a window measured in 3 to 4 hours, something like that.
Absolutely.
So it's not something you go to sleep with and hope that it goes away by the next morning.
Correct. I mean, any indication or signs of weakness on one side of the body, one of the arms, one of the legs doesn't work as well as the other side, the face is asymmetric, or you have a facial droop. These are key signs to immediately call 911 and bring someone to the closest hospital. Difficulties with speech, where you feel like someone is confused, or they're having trouble making words, they're having trouble forming sentences. These are pretty classic signs and symptoms of a stroke.
And again, if you see that, it may be something else, it may be, excuse me, something goes away quickly, but you absolutely have to be in an ED where they can intervene, because it may make all the difference about your life thereafter or not.
Absolutely. It's very important to get to a hospital as soon as possible.
So in the emergency department, I know that we have very strict criteria around when we give these clot-busting drugs, and not everybody's eligible. So what are the kinds of things that would make someone ineligible? So
things that would make someone ineligible are patients who have any risk of bleeding for other reasons. This is TPA, is probably one of the most potent clot-disrupting medications that exists. So anyone who's had recent surgery, anyone who's had recent bleeding problems, anyone who's taking any other sort of blood thinner like a warfarin, or some of the newer anticoagulants we see on television, all of those people are excluded from getting TPA, which is unfortunate, because up until the last few years, TPA has been the only treatment we have for stroke patients. And so there's a lot of restrictions on its use, and it also can't be administered after 3 to 4.5 hours after someone has been seen normal.
And I think that point is really, really important, because I know a lot of people will say, well, I'll wait to see if it'll go away, I'll get in bed and see how it is in the morning. Unfortunately, a lot of people awake with their strokes, and so they don't know when it came on. And unless we're within that window, we know the risk is greater than the potential benefit.
Absolutely. And so that's why we want to be very vigilant about the timing. We want to be vigilant about when the patient was last seen normal, because that's going to really dictate what our ability is for treatment.
So if this comes on, you want to make note of when it comes on, but also get into I keep saying this over and over again, but it's so important for our folks at home. Make note of when it comes on and get to the emergency department. And if it goes away when you get there, well, then you had a TIA, a transient ischemic attack, but it's better to be there than to be home and letting this go on.
Absolutely. When it comes to stroke, it's certainly a better safe than sorry. And to your point, there's a development of an acronym, FAST, for people to take home with them. Signs and symptoms of a stroke. Face, you want to look at the facial symmetry, or if there's a presence of a facial droop. Arm, specifically if there's arm weakness, if a patient has difficulty using one arm or one leg. S, which is speech, so if there's any difficulty with speech, producing words. And T is time, which is really just, again, further encouragement to get to the emergency room if any of those first 3 symptoms are present.
And I think we'd also say call an ambulance, don't drive yourself.
Absolutely. Call 911 immediately.
Call 911, and again, false alarms we prefer to have those than to leave people at home with a stroke.
Right.
Now, what you do has really taken us to the next step.
Sure.
So maybe we can get into that, because again, it's really been only the last several years that we've gone from the point where either the TPA worked, and if it didn't work, well, that was all we could do. Now things have changed even further, really drawing on the experience with heart attacks.
Sure, absolutely. So Like you said, for many years we gave TPA and we hoped that it worked. And for larger vessels, so some of the vessels that are bigger and closer to the heart but are still present in the brain, we know that TPA isn't very effective. Especially for some of those vessels, we think there's about a 30% chance that we can open those blood vessels with TPA alone. And so that's led to, kind of expanding upon what's been developed in heart attack, the ability to physically go up into those blood vessels by accessing a large artery in the groin and traveling all the way up through the aorta, through the arteries in the neck, and directly to that blood clot and physically removing it from the patient's blood vessel.
So, and this is something you would do. This wouldn't be the cardiologist or the radiologist.
Nope.
Something a neurovascular neurosurgeon or endovascular neurosurgeon would do.
This is something an endovascular specialist is trained to do. And there have been several studies over the last 1 to 2 years which have shown that this is very effective and that we can restore excellent neurologic function in a large percentage of patients.
Do you do it just, excuse me, in people who have failed the clot-busting drug, or do you ever do this as the first event?
No, you can do this simultaneously because we don't want to, going back to time being important, we don't want to go and wait for the TPA to fail. We want to sort of do our things in parallel. So while a patient is getting the clot-disrupting medication, we are also setting up to deliver this interventional therapy. We're setting up our cardiac cath lab or our interventional suite where these procedures are done, and so that patients don't lose any time.
Oh, so is this now become routine to engage you at the same time that they're giving the TPA on all patients who are TPA eligible?
They are starting to engage endovascular specialists early, especially in patients who have a big deficit. They have complete weakness or...
Meaning it's a large vessel.
Large vessel. So they have complete weakness of one side of their body. They have a complete language difficulty. So we think that the blood vessel that's blocked is a larger vessel because it's delivering blood to a bigger part of the brain. So therefore, we want to include an endovascular specialist sooner. The problem being there aren't a lot of specialized centers who deliver endovascular therapy, especially locally. This is a new treatment, and so you really need to have the infrastructure in place to deliver this therapy on a regular basis.
I can say before you came, I know at Norwalk Hospital we used to have to transfer these patients either up to Yale or I think up to Westchester Medical Center.
Right.
And that takes a lot of time too.
Sure.
So it almost defeats the purpose or the availability of having that person.
Exactly, and so we think the window to deliver this treatment is expanded from 3 to 4.5 hours to about 6 hours. So any patient who's last known normal or was at their neurologic baseline 6 hours or less is a candidate for therapy. However, the process of going to a hospital and then being transferred to another hospital is a lengthy one, and you lose a lot of time in that process. And so now Norwalk and Danbury are happy to be the first 2 hospitals in Fairfield County to deliver this therapy. And in fact, only 3 centers in the state right now deliver this therapy: Hartford, Yale, and now Western Connecticut.
Wow, and that's so important for our patients because this is stuff that really, really makes a difference.
Absolutely, this is life and death.
Just another brief question though. You say you go in either after, almost concurrently with the clot-busting drug. Don't you have problems with bleeding of the vessel where you put the catheter in and potentially, as you thread it up the vasculature, knocking off other plaques? What kind of risks are there from that?
So there's certainly a risk when you access an artery in the groin. There's a large artery in the groin known as the femoral artery where we are going through to get all the way up into the brain. In terms of bleeding, we're working within the blood vessels. So other than that artery in the groin, there is no other high risk of bleeding on our way up. Certainly there's a risk of dislodging clot. As patients get older, it's normal to have cholesterol or calcium within the blood vessels, and so these catheters can certainly dislodge more clot and can cause a higher incidence of stroke, especially in territories or areas of the brain that were not involved. We call this an infarct in new territory or stroke in new territory. And we think that risk is somewhere less than 10%. We accept that risk because alternatively, without this treatment, patients are at risk for having a huge stroke, and a large portion of them are either going to be severely disabled or die. And the treatment of the bleeding in the groin can be achieved with a small collagen plug. As we remove the catheters, we place a small collagen plug in the groin, and we're very strict about patients getting up and out of bed and resuming normal exercise, assuming they've made a good recovery, until we think that blood vessel is healed appropriately. So we're very vigilant about bleeding.
If you get in within the 6-hour window, and I know this is a difficult question to answer, what % reversibility can you expect? if you open the blood vessel again. Is it better at 1 hour than 3 hours? I presume it would be. But then also, you know, are you giving somebody a little bit of improvement where they would otherwise be, or major improvement?
So a few points. One, we've limited this to large vessel occlusions because we think if your large vessels are blocked, you're going to have a big stroke. And if you have a big stroke, you're going to be disabled and or die. And so that's why our treatment has been reserved for large vessel occlusion, to try and treat just that point. Absolutely, 1 hour is better than 3 hours, 3 hours better than 4 hours, 4 hours better than 6 hours, because we know that over the course of time, more brain will die, and once brain dies, it is irreversible, unfortunately. So what we're trying to preserve is a territory known as the penumbra, which is the territory at risk.
And you know what? We need to take a break, but I'd like to talk exactly about that when we come back, because I think people hear that the brain dies after 4 minutes, and now we're hearing 6 hours can be beneficial, and it's really that penumbra, isn't it, that we're going to be able to treat. So that we'll hold that word, penumbra, and we'll be back after the short break.
Absolutely.
Hi, we're back with Dr. Joshua Marcus, an endovascular neurosurgeon. We're talking about the penumbra, the penumbra of the brain. So yeah, tell us a little bit about, explain that anatomically, if you will, for our guests, our viewers at home.
Sure. So when a blood vessel is blocked and a part of the brain is not receiving oxygen and nutrients that it needs to survive, some of the other blood vessels in the surrounding areas essentially recruit flow to that territory. And so they can almost keep it alive, like a life preserver, for a short amount of time, but eventually they will fail. And so over time, brain tissue dies, but there is this large percentage of the tissue that is, quote, at risk, but not quite dead. That's what we're after.
And that's why we're able to do this, really.
Absolutely. And so once we can restore that blood flow, the tissue that was at risk this entire time, that was hanging on by a thread in a way, now it has new life. And so that we think that tissue can get full restoration of function, but the tissue that's gone is gone. And so the faster we get to that tissue, the better our outcome is going to be.
Josh, do you ever have a problem with bleeding into that reperfused tissue? I mean, especially in big strokes, I know that there's a risk of hemorrhage into them inherently. Is there a risk, the bigger the strokes, with bleeding into that penumbra?
Sure, absolutely. So that's another thing we look at before we're deciding on someone who's a candidate for this procedure, to make sure they don't have a large territory that has already infarcted, because not only will we not do any good, we can actually do a lot of harm by introducing this big rush of blood into a territory that has already unfortunately died.
Can you tell on MRI or other radiographic study how much of the brain has actually permanently dead and how much is in that penumbra?
You can tell on a CAT scan, actually. So we use a CAT scan in the emergency room to be able to tell how much of that territory has already died.
So you go into this with some real knowledge.
Absolutely. So we want to know which blood vessel is occluded. We do a special CAT scan that looks at the arteries themselves, known as a CT or angiogram. And then we do a regular CAT scan to look at territory that may have already died before deciding a patient is a good candidate for this. But in all comers, we think patients within 6 hours have not sustained a fair amount of damage, irreversible damage, and who have a large vessel occlusion. These are good candidates.
About what percentage of stroke candidates would you say are eligible for endovascular intervention?
The overwhelming majority of strokes, when we talk about 800,000 strokes in the United States, are really probably smaller vessel disease. However, say up to 25 or even 40% of patients who come in with stroke may have large vessel occlusion that does not respond to TPA. And so they may be good candidates for endovascular
So there's a
therapy.
substantial number of people who may...
Absolutely. We think that the technology is only getting better, and we're going to be able to treat more and more people with this specialized treatment.
And this means you take call every night, is that right?
That's basically what it means, huh?
You're the guy, so...
It's tough being the only neurosurgeon in Fairfield County to treat stroke in a novel and cutting-edge
That's
way.
one of the problems, though, is as we advance this technology and we have fewer people who are able to do this, I mean, centralizing it makes some sense, but then when you're limited by time, you like to disperse this, and it becomes very difficult logistically.
Right, absolutely. You want to have a center that can perform the procedure enough to be facile and to feel confident that they can do it safely, but also you have enough of these centers so that patients aren't traveling 2 hours to get appropriate stroke care. And right now, you have a stroke Right here, it's going to be very difficult for you if you had to go 2 hours away for appropriate
And
therapy.
before we leave strokes, maybe you could say a few words about what people can do to prevent strokes.
Absolutely. So I think the big things about preventing stroke are no different than the big things about preventing heart attack. Number one is smoking. Above and beyond, smokers have a much higher incidence of stroke. All the other cardiac risk factors we talk about, high cholesterol, high blood pressure, these are big stroke risk factors as well. There is some element of stroke that is sort of inevitable. Patients who have irregular heartbeats, who have carotid artery disease. But I think smoking, high blood pressure, high cholesterol, stress, all of the cardiac risk factors are big.
And remember, if you have high blood pressure and you take medicines for it and your blood pressure gets better, doesn't mean you can stop your blood pressure medicine.
Exactly.
You don't cure it, you just treat it.
Absolutely. So
And
these are the big things we want to focus on with preventative stroke care.
And the cholesterol drugs have also been helpful. The statins that I know have had such a remarkable effect on heart disease. We give pretty much all stroke patients, or most stroke patients, statins after a stroke, don't we?
Absolutely, yeah. Almost all patients with a stroke are essentially considered high cardiovascular risk patients. So they all get cholesterol blocking medications, they get blood pressure lowering medications. A lot of them ultimately get blood thinning medications, whether that's aspirin or some of the newer anticoagulants. So from a medical management standpoint, it is very complex after they've already had a stroke.
Now, last topic on stroke. I'm a man, you're a man. We're used to being on the bad side of everything cardiovascular. Do women have more strokes than men? Is it that they live longer that they have more strokes? What's the story about this gender and stroke risk?
Yeah, no, there's certainly a higher propensity with women and cerebrovascular disease, whether that's stroke or aneurysm. There's just a higher propensity of that disease process in women.
So that's one of the few disadvantages of being a woman, I guess, in terms of. Let me go on to aneurysm, because I know that's another very specialized area that you treat, and used to be a very big operation. Again, I remember in my distant past, those were patients, I remember caring for patients post-operatively who had big-time neurosurgical issues afterwards, brain swelling and also. So tell us about this approach to treating aneurysms, and maybe start off by saying what an aneurysm is so folks at home know.
Sure. So an aneurysm is essentially a ballooning or an outpouching of a blood vessel in the brain, and that results from a weakening of the wall of the blood vessel itself, which is also
like a bubble on the surface
like
of
a little bubble coming off the blood vessel, which is not a problem in and of itself until it bleeds. When an aneurysm ruptures, you have a hemorrhage known as a subarachnoid hemorrhage, which is bleeding around the brain. And that has a high risk for disability, and it has a high risk for death. In fact, a lot of patients who have a subarachnoid hemorrhage don't even make it to the hospital. They die before they get to the hospital.
And this could also affect some younger people, too. So when you hear of a young person dying of a stroke, which is, it's not really a stroke, but that's what I think
It's a hemorrhage, right? Stroke is a broad term that describes both ischemic or lack of oxygen and blood flow type stroke, or hemorrhagic stroke, which is typically the result of an aneurysm. And the average age for a ruptured aneurysm is 50. So this is a young patient population. And so when the aneurysm ruptures, we want to get them appropriate treatment very rapidly, and we want to be able to treat that aneurysm also very rapidly.
So again, in the old days, as I recall, if you made that diagnosis and if this were accessible surgically, in other words, you could take part of the skull off and get in there, the neurosurgeon would put a clip on that at the base of that aneurysm. And again, I just remember the post-operative disasters. It was a very complicated operation. You take an endovascular approach.
Exactly. So rather than having half of your skull removed and having essentially a clothespin put across the aneurysm base, needing to sift through swollen hemorrhage and injured brain, we can do all of this through a groin puncture, essentially a fraction of the size of a penny hole in an artery. So we, again, access the aneurysm all the way up through the aorta, through the carotid arteries that go to the brain, and deliver very small catheters right into the aneurysm.
And this is really amazing. I don't think a non-physician or non-anatomist would recognize, but we're talking about getting up there into some pretty small vessels, pretty important small vessels.
Absolutely.
Up there in the brain itself.
Yep. We can deliver these tiny catheters right into the aneurysm, and we can deploy very tiny platinum springs, they're known as coils, which sit in the aneurysm itself and essentially block off any additional blood flow into that aneurysm and prevent it from bleeding any further.
Now, again, I still have trouble picturing this in my brain. a spring doesn't seem to have enough surface area to block off a whole bubble. How does that work? Is it more complex than that, or is it the clotting around the spring that ultimately stops the bleeding?
It's twofold. They have a complex morphology, a pre-shape to them, so that they can fill into aneurysms, which are various shapes and sizes.
So you actually look for the shape and decide on the spring that will fit into it.
Oh, the shape and the size. The size is important also. So the coils have various sizes. They can go as small as 1 millimeter. They can be as big as 15, 20 millimeters. And so sometimes, and very often, it takes more than one coil to secure an aneurysm or treat an aneurysm. But on top of that, the coils actually promote thrombosis. They promote clotting within the aneurysm. And so combined with the actual coil mass, the clot within the aneurysms prevents it from bleeding any further.
How soon after you put the coil in does the bleeding stop in general? We're talking about seconds, minutes, an hour?
Usually within minutes. The clot starts forming pretty quickly. We keep patients on blood thinning medications actually during the procedure so that we don't get any new clots that form on the catheters or while we're putting in the coils. But right after that, there's clot formation within the aneurysm.
And we've run out of time. I'm going to ask you one last question. Once it's clotted off, once you've got the spring in there, the coil, is that it? The aneurysm's safe? Won't bleed again?
Exactly. Aneurysm's cured.
Wow, that's amazing. That's really an amazing thing. So I want to thank Josh. When we come back, we're going to have a health question that also focuses on neurology. But right now, let's take a look at some of the upcoming events sponsored by Western Connecticut Health Network. Hi, today's health question is, what can you do to reduce your risk of stroke? I know we've talked about this a little, Josh, but maybe you could summarize. There's a lot we can do to reduce our risk of stroke, isn't there?
Absolutely. I think there's several lifestyle modifications you can do to reduce your risk of stroke. And the biggest one is if you smoke, stop smoking. I think smoking is one of the #1 cause of stroke, whether it's ischemic stroke or hemorrhage or aneurysm formation. Smoking is a big risk factor. So stopping smoking is going to be #1. Control of blood pressure, control of cholesterol. These are two other big lifestyle modifications. Appropriate medication for blood pressure and consistent blood pressure lowering. These are all big lifestyle changes that I think reduce your risk.
And then, exercise and healthy diet and all the things that we talk about all the time.
Absolutely, all healthy lifestyle.
Anything in family history of aneurysms, is there something there that people should be aware of?
There is. There is a family history of aneurysms in up to 10% of patients. We don't really worry about it. If you've had a first-degree relative who has an aneurysm or who's had a hemorrhage, that doesn't mean you need to go run and be screened. If you've had 2 family members with aneurysm, at that point we start advocating for some screening.
So that's helpful. So you should be aware of your family history, which is true for across all diseases, but 2 first-degree relatives who have had an aneurysm, be aware of it and maybe get screened for it.
Absolutely.
And get your aneurysm closed before it bleeds.
Exactly.
This has been extraordinarily helpful. Welcome to the area.
Thank you.
And I thank you myself, but for all the people out there that are going to be saved by your intervention or helped by your intervention, that's just fabulous. We're really glad to have you, Josh.
Thank you very much. I appreciate it.
And so if you at home have a question you'd like to ask me on Health Talk or ask our guests, please contact us at healthtalk@norwalkhealth.org. I want to thank today's guest, Dr. Joshua Marcus, for coming on the show. I will see you next week on Health Talk.